السلام عليكم جميعا. مرحبا بكم في أجواء الرياض. We really would like to have you around us, but what can we do? COVID decided that we don't see you. Today we're going to talk about obstetric anesthesia. We have a very distinguished speaker. I just would like to give one announcement that after our session we're going to have a break till around 13:30. And we're gonna give you more update from the room, from the news, for everything. The lecture is so great. I would like first to give the chance to my colleague, Dr. Hani, is the newcomer from London, Ontario, the neuroanesthesia, who is really excited to present our next speaker. So, Hani, have fun.
Thank you so much, Dr. Nasser. And thank you for your attending the weekend. We'll make it short so you can enjoy the weather and the lectures as well. It's with great pleasure I want to present Dr. Eatimad Bantan, obstetric anesthesia in Makkah Al-Mukarrama Maternity and Children Hospital. She will talk about very interesting topic and very important topic in the anesthesia and especially in the obstetric anesthesia, which is about antepartum hemorrhage, anesthesia challenge. Mike with you, Dr. Eatimad.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Hani, for the introduction. And I would like to thank the organizing committee for such a great event in our specialty. Just for the correction that I'm a consultant anesthesia, I'm not specialized in the obstetric, but I'm very interested in this specialty. Before I start, Before I start in my topic today, I would like just to share you a case that happened 2 years back. A young lady was pushed rashly from the delivery room to the OR for emergency cesarean section because of severe fetal bradycardia. And on arrival, the patient was restless, in pain, pushing hard. So once we shift her to OR table and start the cesarean section, immediately after the delivery of baby, the patient had a cardiac arrest. And at that time, the team was thinking about the amniotic fluid embolism. But during the operation, it was discovered it was because of severe bleeding that was concealed and not expected. So this is my objectives in my lecture today. I'm going to mention about the problems from the obstetric hemorrhage, a little bit about physiological changes in pregnancy, what are the complications that expected from antepartum hemorrhage, what challenges that faced by the team at that time, and just few guidelines for the obstetric hemorrhage. For the problem of the obstetric bleeding patient, yes, we know that the hemorrhage is the leading cause for maternal death worldwide. And in our country, the maternal mortality rate is around 24 per 100,000 births. That was in 2008, and dropped down to 17 per 100,000 births in 2017. And the commonest cause was bleeding during delivery. And from that time till now, it became the second leading cause for maternal morbidity and mortality. And this picture by the WHO 2010, as you can see that the hemorrhage was the most cause of maternal deaths in the West Asia. That's between 1997 and 2007. Little bit of physiology during the pregnancy. We know that the pregnant lady had a lot of physiological changes, subhanAllah, to accommodate the growing fetus. So regarding the circulatory blood volume, it will be increased to 40 to 50% at term. And if we calculate the blood volume at that stage, as 100 ml per kg. In a 70 kg woman, it will be 7 liters. And the cardiac output also increased to 50% at term. And uterine blood flow also increased to around 850 ml per minute. And during labor, uterine blood flow will be around 2 liters. So theoretically, if this patient bled, she will lose her entire blood volume within 10 minutes. In this table, that's to show you the expected blood volume in according to the maternal weight. So if the mother is around 50 kg, her estimated blood volume will be 5,000, and if she lost around 2,000 ml, she will consider as she lost around 40% of her blood volume. A few definitions regarding the obstetric hemorrhage. For antepartum, it is a bleeding that occurs from genital tract during pregnancy after the 24 weeks gestation and prior to birth of the baby. We'll consider it as minor if it is less than 500 ml and major if it is more than 1,000 ml. And also with the clinical signs that's suggestive of significant bleeding. And if it is more than 2,500 ml, it will be considered as massive obstetric hemorrhage. Regarding the postpartum hemorrhage, the loss of blood from the genital tract within 24 hours of birth of a baby. Again, it is minor if it is between 500 to 1,000. It is major if it is more than 1,000 ml, and it's considered massive if it is more than 200 ml, or a rate of blood loss of 150 ml per minute, or of loss of 50% of blood volume within 3 hours. So in massive obstetric hemorrhage, that triggers the massive obstetric hemorrhage protocol is defined as blood loss that is uncontrolled and ongoing with a rate of blood loss of 150 ml or more per minute, or more than 2 liters. So what's the challenges that are being faced with the team during that time? It's really a scary situation. There is a lot of adrenaline going through the mother and a lot of adrenaline in the entire team. And lack of personnel and resources could be an issue. Although I consider the lack of leadership and decision-making is the main issue during this situation. Also, the list of tasks that have been recommended by the guideline sometimes is huge and can be time-consuming if the team are not trained on that protocol. For the causes of obstetric hemorrhage, it will be classified according to the periods. For antepartum, we have a placenta previa, placenta abruption, coagulopathies, and uterine rupture can cause severe antepartum hemorrhage. And during delivery, laceration for the vaginal tract could be a cause of massive postpartum. And in the postpartum, the main cause is the uterine atony. It comes through and the spectrum of placenta accreta, and could be local cause like cervicitis, dysplasia, or carcinoma. Few pictures regarding the causes of obstetric hemorrhage, like a placenta previa. We have the totalis and low line. And regarding the abruption, this is a picture. This is a concealed abruption that can cause a concealed hemorrhage. Could be not presented well with the patient. And this is the spectrum of placenta accreta. We have the just invasion of the deciduum, or the invasion of the uterine muscle, or invasion outside the uterus. What could be a reason that not expected, like here in this picture? This is a uterine artery pseudoaneurysm. And in our case, I will tell you what was the reason of bleeding in my case. In a pregnant patient, the same we apply the stages of hemorrhagic shock that have been created by the American College of Surgeons with a little bit of modification. So in stage 1, the bleeding is more than 500 in vaginal delivery or more than 1,000 ml in cesarean section. The patient still have a normal vital sign and no much changes in her clinical picture. If the bleeding is more than 1,000 to 1,500, still there is no change in vital sign and no in clinical picture. Such amount of bleeding could be fine with a patient that is ASA1, no other diseases, but in a mother with a comorbidity, it will be a significant bleeding for her. In stage 3, there will be an ongoing bleeding, the estimated blood loss more than 1,500. There will be a lot changes in the vital sign, index shock, and the decrease in urine output. And in the other labs parameter will be changes. And in stage 4, that we don't want to reach it, cardiovascular collapse could appear in the setting and profound hypovolemic shock that could be irreversible. So in the complication for the antepartum hemorrhage, we have here a 2 patients, the mother and her baby, and we need to save both patients. For the mother, it depends on her baseline, whether she had other comorbidities. With the severe bleeding, she could have acute hemorrhagic shock, acute kidney injury, complications from the blood transfusion, coagulopathy, TRALI, that's transfusion-related acute lung injury, and hysterectomy, which is really considered an issue for a lady who's in reproductive age, and finally the maternal death. In the baby could have hypoxia, could be delivered prematurely, or could involve a fetal demise, or deliver with a congenital malformation, and could be delivered with a birth asphyxia and live long with sequelae of cerebral insufficiency. In the management of such patient, the important thing is the patient assessment. So to give this patient early as possible to manage her well. So the important thing is the clinical sign. You have to quantify the blood loss, although it is difficult, especially if it depends on the visual assessment, and it will be underestimated. For example, in the American College of Gynecology guidelines regarding the hemorrhagic assessment, they are assessing the sponge estimated if it is a 2 by 2 by 5 mil, if it is soft sponge, and if it is 4 by 4, it is estimated as 10 mil. You have to weigh what's collected in the section. You have to weigh what being under the drapes or on the floor. And after that, you have to subtract the amniotic fluid and irrigation that been used during the operation. So we'll come to the choice of anesthesia here. With the ongoing resuscitation for the mother, we have to anesthetize the patient emergently to deliver the baby, and to deliver the baby as soon as possible. So whether it is spinal or general, it depends on the patient baseline. And at that time, you have to call your team because we need more hands to help in such case, and to bring the appropriate blood product. So those who advocate use for epidural anesthesia, if there is a fetal bradycardia, we need such a quick technique to anesthetize this patient. For those who advocate for epidural anesthesia, they would like to avoid the risk that has been associated with general anesthesia in a pregnant patient. And retrospective study found that no increase in morbidity, and there is decrease in blood loss. And for those who advocate for general anesthesia, they want to avoid the sympathetic deleterious when potential use of massive blood loss. And they are expecting that the patient must progress to hysterectomy, which may require conversion to general anesthesia. What do you have new in obstetric, in the management of obstetric hemorrhage? massive transfusion protocol been implemented in some institution. Use of cell salvage intraoperatively, use of obstetric hemorrhage bundle, whether to transfuse fibrinogen concentrate or not, to give a tranexamic acid or not, and in the use of arterial embolization to save the mother in such a situation. For the massive transfusion protocol, this data coming from the military army found that lower ratio of red blood cell and fresh frozen plasma and platelet will improve the outcome. So the simple protocol now is commonly used, that 1:1:1, 1 packed RBC, 1 fresh frozen, and 1 platelet. Still, there is limited data in the use of this protocol in the obstetric field, because the challenge in the massive transfusion protocol in an obstetric, that the etiology of hemorrhage is different from the trauma, and it needs a lot of cooperation between the department, with the blood bank and the operation and the operating room. In the cell salvage use intraoperative during such situation, in obstetric field, there is a concern about the contaminant, either from the amniotic fluid or the fetal blood cells. So there's a possibility of amniotic fluid embolism and maternal immunization from the fetal RBCs. It needs a training to start this the cell salvage. Actually, in our hospital, when we brought this machine, they forgot to buy the filter for amniotic fluid, so we did not use it. For the arterial embolization, it needs a logistical issues regulated prior to its use. It needs an good organization. In my hospital, we have only just an obstetrician and a pediatrician. So if we need other specialty, we have to call them from outside hospital. When we start this method with the cases of placenta Accreta 4 years back, we have to arrange between the hospital. So we have to send the patient to King Abdullah Medical City to do the femoral cath, to set the femoral cath, and the interventional radiologist will come with her back to our hospital to have the cesarean and and he has to come to follow up this patient for the complication of this femoral cath. And in some institutions, they may need to transport the patient to radiology suite, and this patient could be unstable from the bleeding. I'll come back to my case. As I said, that the patient was conscious, restless, in pain, pushing. When we connect her, and we found that during shifting her to our table, the cannula, the only cannula that there was dislodged. So when we tried to insert another cannula, the patient have many trials already in the delivery room. Her vital sign, when we connected the monitor, the heart rate was around 130. And blood pressure at that time was not measuring. And unfortunately, we thought that because there is a problem in the machine before, we faced it before. So with the pushing of the obstetrician to deliver this baby, we start induction, rapid sequence induction. And when they opened for the cesarean, we observed that a lot of blood was coming from her abdomen before the uterine incision. And the baby delivered within 1 minute, but it was delivered unfortunately flat. And suddenly after that, the mother arrested. But we are lucky that, alhamdulillah, that it was less than 1 minute. We gave a dose of adrenaline. And with a few chest compression, the return of spontaneous circulation of the mother.
Dr. Matt, 2 minutes.
Okay, we are almost finishing. We called our senior, and the suggestive of according to the vascular surgeon, that there was a lot of varicosity, internal varicosity, and that was the only explanation of the bleeding. The patient, alhamdulillah, survived, but unfortunately her baby was died. So how we can improve our care? We have to be ready. We have to implement the protocols and train our staff for that protocol. There are a lot of guidelines, international and national, regarding the obstetric bleeding. We have to put our protocol regarding the guidelines, as I said, and we have to train the staff, whether by to train our staff by multidisciplinary simulation. We have to emphasize the process system and teamwork. We have to equip ourselves with the need, and important debriefing after each case is very important. So in summary, to have a happy mother and baby and team, and with a less morbidity and mortality, it has to be simultaneously a timely action, resuscitation, and control of bleeding. That could save the life. Thank you.
Thank you so much. Thank you so much, Dr. Eatimad. Dr. Nasser, to you. I think we'll take the question and answer at the end of the session.
Sure. We really enjoy the talk. I think you can hear my voice, Hani, صح?
Yes.
So we really enjoy the talk. It's really a current big situation, especially in Mecca region, where you have most of the people is unplanned for C-section, doesn't visit the antenatal care. And having somebody like Eatimad who's really interested in having the people at the end of the light, I think she's an ICU as well with the anesthesia, make her see the end result of our sometime bad work. Now we're gonna shift to another mode of speaker. We have Dr. Hanan, who's coming from far away, from London, Ontario, who invested around 5 years in London, Ontario, and then she decided to go to Toronto to do for 1 full year of obstetric anesthesia. She came to Jeddah, unfortunately, and she have been appointed as a program director, make her life busy, and we're gonna make her life busy now. Guess what? Our international speaker is really welcomed. I would like to welcome everybody. We are around 500 or 600 people in the conference. We are very sorry not to see you, but please welcome Dr. Hanan, and I will give her the mic and we give her the share. Hanan, we like you. Dr. Eatimad, wait for us. We're gonna have a lot of questions. Fadl, Dr.
Okay, good morning, everyone. Thanks, Dr. Tawfeeq, for the nice introduction. I am happy to be here at the first SAS virtual meeting to talk about high-risk pregnancy. If you would agree about the perfect birth. Okay, my objectives are first to define each one of the high-risk category. I will briefly talk about the pathophysiology. I'm going to describe the anesthetic management, and I'll give you a summary in the end. High-risk pregnancy is a broad topic. It affects about 20% of all pregnancy. It could be high risk because of fetal causes, medical and obstetric causes, and those group of women who become high risk if they get exposed to anesthesia, as in a morbidly obese patient, difficult airway, and coagulopathic patient. Pre-anesthetic evaluation optimally for high-risk patients should be done in the late 2nd trimester or early 3rd trimester, even if vaginal delivery is planned. This practice offers the opportunity to provide patient with information, optimize medical condition, and discuss plans and preparation for the upcoming delivery. Focused history and physical examination consistent with the ASA guidelines for obstetric anesthesia is recommended. This slide shows the practice guidelines for obstetric anesthesia by ASA. And as we all know, practice guidelines are recommendations that help the practitioner and the patient in making decision. They are not intended to replace local institutional policies, and their use cannot guarantee any specific outcome. Okay, so I just highlighted in red those topics I'm going to focus. So maternal cardiac disease, I'll talk about aortic stenosis and Eisenmenger syndrome. I'll talk about active thromboembolic diseases and difficult airway. Uteroplacental factors, I'm going to focus on placental abnormality management. Fetal factors, known fetal structural anomalies which might necessitate intervention during pregnancy, such as ex-uterine intrapartum treatment. I'll briefly talk about multiple pregnancy as well. Placental abnormality spectrum, as we all know, peripartum hemorrhage remains a leading cause of maternal mortality worldwide. There is little difference in blood loss between uncomplicated elective cesarean delivery and uncomplicated planned vaginal birth. However, emergency C-section is associated with greater blood loss. This graph shows the maternal specific mortality death. As you can see, from 1987 till 2013. Earlier, it used to be hemorrhage. Anesthetic complications were rare throughout the years, but in the last 10 years, cardiovascular condition and cardiomyopathy has become more popular. Okay, placental abnormality spectrum. You gotta discuss with your obstetrician what's the plan. So if he's gonna do extraoperative therapy, which means manual removal of the placenta, planned cesarean hysterectomy, or conservative treatment, leaving the placenta in situ. Planned cesarean hysterectomy is currently recommended by Acog. Conservative management, it's recommended by International Federation of Obstetric and Gynecology, and it should be discussed carefully after explaining the risk, uncertain benefit, and it should be considered investigational. Okay, does it really matter GA versus neuraxial? Basically, it's becoming clear that in the appropriate circumstances, the type of anesthetic is but first consideration. Adequate intravenous access, massive transfusion protocol, availability of resuscitation drugs and equipment are probably more critical than the choice of anesthetic technique. This is the checklist for placenta Accreta. Actually, it was developed by two of our obstetricians in King Faisal, and I would recommend that each of you develop one if you're not already. This recent literature on pulmonary aspiration during pregnancy, in SCORE project, they looked at the serious complication related to obstetric anesthesia, where they had more than 5,000 general anesthetic with no report of aspiration. However, in recent French inquiry into maternal death, 1 out of the 7 deaths occurred is because of ARDS caused by pulmonary aspiration.
Sorry to interrupt you, but can you go to the slide of the checklist, because it's really a nice one.
Okay, so this is the checklist. So it was developed, as I said, by two of the obstetricians. They have, like, upon admission, what to do, and then consultation. You can see anesthesia in ICU, then the booking, the blood bank. Okay. Okay, Mark Lee, he looked at the conversion rate. 27 patients had GA. Out of 27 undergoing GA, 3 had difficult intubation. I think Dr. Eatimad, she had talked about postpartum. So this is the Acog practice bulletin, October 2017, and it replaced the practice bulletin from 2006. Thurn, he looked at the risk factor in Nordic countries, and it was large population-based cohort study. As you can see from the table that if a parturient has a history of C-section, the risk of having a placenta accreta is higher. And of course, if she had a placenta previa and she was above 35 years of age, then the risk is very high. I'm gonna briefly compare planned cesarean hysterectomy and conservative management regarding the outcome. So if you look at the packed cells more than 4, it's 42 to 44%, the rate. Then we go down to like DIC 20 to 38%, ICU admission 28 to 65, and the death rate was 0. Conservative therapy, packed cells more than 4 is 15%, sepsis 4%, ICU admission 25.7, and death 1%. This is markedly, so neuraxial anesthesia during cesarean delivery for placenta previa with suspected morbidly adherent placenta. They had a total of 137 patients. 129 had non-emergency cesarean section. Out of 129, 122 primary neuraxial, and 7 patients had primary GA. Out of 122 patients, 102 had neuraxial only, 15 they converted from neuraxial to GA, and 5 they had early neuraxial failure. So anesthetic management of placenta accreta, of course you have to do the case in the main OR. Personally, I put 2 large bore IV. I don't put central venous catheter unless patient is sick. You have to ask for the blood to be in the room prior to induction. And of course, neonatology consulted and ready. There is still lack of consensus as to which patient require type and screen and which patient require cross match. However, like at King Faisal, we always don't start any case of placenta accreta before ensuring that we have at least 6 unit blood in the room. Okay, we move on to thromboembolic diseases. Recommendations are based on case report series, pharmacodynamic and kinetics. Newer drug recommendation based on elimination half-lives. So thromboprophylaxis is the key prevention to reduce venous thromboembolism. Thromboprophylaxis have major impact on use and timing of neuraxial procedure in obstetric population. Why do we use low molecular weight heparin? Because it's easier to administer, it's effective, and it produces more predictable anticoagulation response and don't require routine monitoring. Its elimination is exclusively renal. Okay, these are new recommendations for pregnant patients since the previous guidelines did not specify a time interval between the sub-Q administration of unfractionated heparin and the neuraxial block. And it's based because of the pharmacology of unfractionated heparin, which result in significant anticoagulant effect that persists 4 to 6 hours after administration. So if you are giving high dose, like individual dose more than 10,000 BID or daily dose less than 20,000, then you have to do the neuraxial 12 hours after the last dose and after checking the PTT. And if you are giving more than 10,000 per dose or more than 20,000, which is in the therapeutic treatment group, then you have to wait for 24-hour post-class dose after checking PTT. Okay, we all know about this. Actually, you can take a snap of this slide because myself, I get confused and always look up at the saved slide from my presentation. Okay, this is quite interesting. The reason is that like maybe a month ago, I was involved in a C-section, and specifically the obstetrician told me, doctor, please don't give diclofenac and Toradol, which we do routinely for our patient post C-section. And her explanation was that she had experienced 2 patients with surgical bleeding. So in patient receiving non-steroidal anti-inflammatory drug, we suggest caution in the performance of neuraxial technique. If the concurrent use of other medication affecting clotting mechanism, such as antiplatelet, oral anticoagulant, unfractionated, and low molecular weight heparin is anticipated in the early post-op because of the increased risk of bleeding complication. Risk of spinal epidural hematoma in obstetric, it's 1 in 200,000 for epidural and 1 in 250,000 for spinal, compared to 1 in 3,600 in elderly orthopedic female patients. So in a summary, thromboprophylaxis need to be timed for neuraxial block for most planned elective deliveries. Neuraxial block versus GA with competing interest of fetal well-being need to be customized according to clinical situation in emergencies. This is Thrombosis Canada app. You can easily download from Apple Store and use it as a quick reference. Covered by Dr. Eatimad. This is a landmark study from the group in Toronto at Mount Sinai, where they found oxytocin pretreatment attenuate oxytocin-induced contraction in human metrium in vitro. Found it interesting. International consensus statement on the use of uretonic agent during cesarean. And of course, they say that the recommended dose of oxytocin may be to be increased in women with risk factor for uterine atony. But you have to be careful since oxytocin can cause hypotension and reflex tachycardia and can be dangerous in cardiac patients. So all these uretonic drugs, I'm not going to go in details, but for our fellows and residents, you should know the dose, maximum, side effect, contraindication, and route of administration. This slide shows the cause of pregnancy-related death toward the end of pregnancy. So during pregnancy, it's other non-cardiovascular medical condition. Day of delivery, most common cause is hemorrhage. First 6 days, hemorrhage and hypertensive disorder of pregnancy. First month infection, and up to first year after delivery, cardiomyopathy. Okay, move on to intervention during pregnancy for fetal surgery. Ex utero intrapartum treatment, it was designed back in 1980s to reverse tracheal occlusion in babies with congenital diaphragmatic hernia. And since then, it gained wide popularity to treat babies with cervical neck masses or CCAM. And actually, we were fortunate to have one case in King Faisal just over 6 months back. I wasn't involved in that case, but other colleagues, and it was very successful. That baby had neck mass. Okay, so all these interventional during pregnancy for fetuses, some of them are effective, others are investigationals, and majority are case reports. However, the intervention that has perhaps had the greatest effect on perinatal outcome is antenatal maternal administration of steroid.
You have to abuse you, Doctora, so this is my right. So you have 2 minutes or 3 minutes to finish.
2 minutes? Okay.
1 minute and 59 seconds now.
Okay, pictures of airway manipulation in exit surgeries. So, conclusion, maternal fetal surgery is complex that require skilled team of physician, nurses, and excellent team communication. Multiple gestation, again, they're high risk because they have a lot of physiological changes. They're more difficult airway, more full stomach, and more aortic compression, exaggerated obstetric complication. Demanding a perfect working epidural is the key for management. The first thing I would do when they get admitted to antenatal is to put 2 large bore IV, because once they start bleeding, they shut down their veins. Difficult airway for junior resident. The reason why we consider pregnant women difficult airway is pharyngeal laryngeal edema. They have large breasts. They are often obese, full dentition. Resources for airway management. Routine versus difficult. Okay, this is very important. So difficult airway algorithm for pregnant patient is unique in the decision tree where you cannot intubate but can ventilate, depending on the presence of fetal distress on the heart monitor. So if you cannot intubate but can ventilate, you have two options. Either awaken the patient, because mom comes first, or continue anesthesia by bag mask ventilation while assisting maintain cricoid pressure. And this is called fed intubation breath. Okay, pregnancy heart team, it's level C evidence, so essential personnel should be obstetrician and specialized in maternal fetal medicine, anesthesiologist, cardiologist, and critical care obstetric nurse, ECMO specialist, and perfusionist. WHO classification of maternal cardiac diseases. I'm not going to go in detail, so you can look it up. Class 1, Class 2, 6 to 10% cardiac event, Class 3, Class 4, and Class 5. So Class 5 pregnancy is contraindicated, and those are pulmonary arterial hypertension, severe mitral stenosis, severe symptomatic aortic stenosis, severe aortic dilation, more than 45 in Marfan, and other heritable thoracic aortic diseases, and Fontan circulation with any complication. Delivery mode. Some patients with very high risk cardiac may not tolerate fluctuation in cardiac output or Valsalva during vaginal birth. For many of these, regional anesthesia during labor and delivery provides sufficient pain relief. And the direction of anesthesia cardiac disease patient undergoing vaginal delivery should be offered epidural labor analgesia, and cardiac disease patient undergoing cesarean delivery should have neuraxial anesthesia if possible. Indication for C-section. Eisenmenger syndrome, chronic right to left shunt, symptom and signs of right heart failure, avoid hypotension. They have high mortality rate, up to 50% because of thromboembolism.
Special request came to give you more time, Doctora, so you can have another 2 minutes.
Okay, thank you. Hemodynamic goals, avoid any myocardial depression, avoid increase in PVR. Management of C-section, you have to titrate your epidural very well to avoid any hypotension, be careful about aortocaval compression, and balance the risk of RSI and aspiration. I'm not going to go through the preeclampsia diagnostic criteria. Few slides on heart failure. It's common because of preeclampsia during pregnancy. Most occur in the postpartum period because of uterine autoperfusion. They need supportive measures, and you can terminate pregnancy if maternal well-being is needed. Some of the registries, Roback and Zahara, where they look at related maternal death, whether it's heart failure or other non-cardiovascular complication. PIH options, and each option pros and cons. You have to communicate with anesthesia early to decrease the need to rush GA. Aortic stenosis, areas and gradient. Patient tolerate pregnancy well, but maternal mortality can reach 17%. Pathophysiology, they have low compliance ventricle, sensitive to volume depletion, dependent on atrial kick, prone to subendocardial ischemia. They have ineffective CPR, so if they arrest, they cannot come back because it's down spiral of hypotension, left ventricular ischemia, and so on. Place your pacing pad early. Hemodynamic goals preload, you want to keep it full. After load, avoid hypotension. You don't want tachy or bradycardia, and avoid aortocaval compression. Option for anesthesia, GA is the gold standard with etomidate, not ketamine or propofol. For moderate to mild titrated epidural, cesarean delivery is reserved for obstetric indication. Labor analgesia for mild to moderate in the absence of RCT, still neuraxial analgesia is safe, provided no significant valve lesion or pulmonary hypertension, and you should be vigilant with the blood pressure monitoring. In a summary, so avoid aortic compression, invasive monitoring early. SB prophylaxis for vaginal delivery at the time of membrane rupture needed. So last slide. In summary, communication and the teamwork is so very necessary between our OB and anesthesia specialty to optimize both maternal and neonatal outcome. There is a need for further study on anesthetic need for high-risk parturian. Successful anesthesia will depend on technical skills and understanding of maternal and fetal physiology, pathophysiology of the pregnancy, induced complication, and pharmacology of different drugs and their interaction with anesthetic technique. Thank you. I hope you all stay well and safe.
We really enjoy the talk. It's full of things. Sorry to rush you, but I think in my sessions, the people have a lot of questions that we didn't touch. So allow me to say if anybody would like to select one of the QA and start. And because Dr. Hanan, you just finished the talk, we'll give Dr. Bantan the mic to see if she wants to answer any of the question. And I think Dr. Eatimad. Open the mic.
Yes, Dr. Nasser. There was one question about epidural. What about epidural? I think he's asking the epidural regarding in the case of hemorrhage. As I said, the regional could be, it's according to the maternal situation and your situation and the cooperation with the surgeon. Epidural needs time to start, and if there is a fetal distress, there is no time answer unless you will do it as a combined spinal epidural.
Let's do a quick vote. People are asking, what is your cut of the platelets? This started with what one? For us in National Guard, we will say 100. We will say 75, but I never announce it. So I will say 100. Dr. Hanan, platelet count?
Yeah, 100 is a reasonable number, but I would look at the trend as well and go from there.
No, because people now are looking for number only. I don't want to discuss more because it's like a fellowship. So 100. Dr. Eatimad?
70.
تخوفيني. Okay, people will follow you. Be careful. They will say Eatimad say 70. Dr. Hani?
In King Faisal Riyadh, we go with 100 always.
The 75 number came from one of the people mentioning that if you look at the platelet smear and see the maturity of the platelet, then you can make a decision of 75. But yes, 70 or 75 decision is in place. Dr. Hanan would like to say something.
No, I didn't. It's okay. Like 100 is fine, but you gotta look at like if it's only for labor analgesia, then you look at the trend. But let's say you have a patient
for epidural, 100 for sure. For a spinal, small needle, we can go debate with Dr. Eatimad. 75, 100 is okay. But remember, the epidural is we really need to be careful. One epidural hematoma will make your repetition. I remember our Professor Hani, always I say it in the teaching that he write in his door, people only remember my mistake. I don't want him to remember my epidural hematoma. I didn't have it yet, but when you go down less than 100, you may have one, so wait for it. It looks like people start to wake up. We have 513 people around, so we'll start from below. I would like to ask about severe fetal distress, full stomach, and difficult area. What is the option? Call sick. Don't come to the home. This is really, I don't know what you do. Guys, what are you going to do? Somebody with full stomach and fetal distress. The answer is GA for me with 5 suction, not 1, not 2, not 3, not 4, and rapid sequence induction, and prepare for it. And then you go ahead. Now, people, I think, in my opinion, people forget that the new medication, propofol, causing laryngoscopy reflex blunting. The sodium thiopental does not cause the property. So rarely I see a vomitus during rapid sequence induction in my life. Dr. Hanan, Dr. Eatimad?
Yes, as you mentioned, Doctor, that and Alhamdulillah, knock wood, we haven't seen any aspiration so far. And as I said in my talk, we talk about aspiration in pregnancy, but still there is no report of aspiration recently, and there was only one case of aspiration because of GA. So I routinely give them metoclopramide to decrease the risk of aspiration, and I will balance, like if the spinal, it takes 2 minutes in my hand, then I will communicate with the obstetrician and tell him if I can do spinal and then avoid GA, but it all depends on the circumstances.
Again, the more that we do the spinal, the quicker we will do it. I would like to ask all the panel. We all know that there is no ASA1, or I mean no E1, okay? But the obstetrician book all their cases E1. Is there any way to know if the E1 is really E1? The answer was very strange from one of the guy in the state. He said, if you see the obstetrician, scrub, ready to go and to cut, no, it's E1. If the obstetrician is roaming around you and talking to you and convincing you to have GA, just ignore him, because it looks like a body language that you're going to read it. So the person who asks us the question if the patient full stomach and so on, look at the body language of the obstetrician. Look at the data you have and just take a decision. There is a very interesting question about do you recommend thromboblastotomy or postpartum hemorrhage? Who would like to answer this question? I think Dr. Eatimad raised this issue, the thromboblastometry in postpartum hemorrhage.
It's been advised to use it, but I don't know. In my hospital, we requested, but we don't have it, and we don't have an experience on this.
Dr. Hani.
I don't use it in obstetric, but I think it's not a new thing. We should start using it, and it's recommended for postpartum hemorrhage.
We use it, but the problem with the obstetrician cannot even read an ECG. So how do you want him to read that? Those are the problem. He's going to call you every minute to interpret it for him. So if you would like to say recommended, yes, recommended, but the obstetrician need to read it. He cannot read it. So the answer, go back, go for the basic, look for the clinical signs, and go on. Let's select another question. Hani, let me give you the chance to run the talk. You can select any question you want.
So Dr. Somro asked about cannot intubate, cannot ventilate. Will you still insert LMA, and any role of fauna front of neck approach? Dr. Eatimad, if you would like to answer this question.
I would like to suggest Dr. Hanan to answer.
Okay. Thank you. Yeah, so still, alhamdulillah, we never saw such a case, and we hope we don't. But as it showed for ASA, difficult airway algorithm for obstetric. So mom comes first. If you get difficult intubation and still you can ventilate, you can apply cord pressure, give the aspiration prophylaxis, and carry on with face mask, or worst case scenario, you can put an LMA and go from there.
I like it. You know that I was surprised that Japanese did 2,000 cases with LMA for C-section.
Wow.
Jordan, they did around 2,000 or 3,000 cases for elective C-section. Remember, the LMA start to show some safety, but the study did not validate it. Now, do you want the family to sue you, or you want the patient to sue you? For me, I will put LMA. Even if I aspirate, I will say apology for him. After the case, he will not sue me. But when he died, and you say that it was a difficult intubation, then the family sued you, then you cannot go out. So again, the lower the incidence of the problem, I will select it, and then we will see. I believe, as Doctora said, that sometimes even some hospital doesn't have a LMA. And sometimes we go to the basic, just face mask and get rid of the baby and make the mother safe. Then look, while you're calling for help, you can find another one. And people remember that the help doesn't mean you're weak. The HELP means that you have too much epinephrine in your body. Your brain doesn't think straight. When you call somebody else and the person come to you, the ideas will come, and then you will feel relaxed, then your decision will be better. Dr. Hani, they are, because they saw you as a neuroanesthetist, they're asking about nitrous oxide use in obstetric. Hanan, Eatimad, what do you think?
I did not use nitrous since more than 2 years.
I don't know this question, but everybody know that if you look at the people who have intraoperative awareness, they were women. Not because they are women, because they are pregnant. Because we use half of the MAC. So you don't want to use nitrous? I say yes, don't use it. But within 1 year, you have all your patients will complain you that they were aware while they're asleep. So up to you if you want to resign, or somebody asks you to resign, don't use nitrous oxide. Nitrous oxide is bad. I don't believe in this talk. Nitrous oxide is safe drug because it is very short acting. And nitrous oxide good for pregnant women because it helps in case of intraoperative awareness. That's my opinion, and I can share Dr. Hanan and Eatimad and our neuroanesthesia if you would like to add.
In basic awareness, okay, go ahead, Dr. Hanan.
So basically, I use it, of course, if I'm doing C-section under GA. And the only downside is nausea and vomiting, but we give anti-nausea and vomiting medication. For labor analgesia, it's been used still. The only problem now with the COVID-19 pandemic, so you have to have your precautions and the recommendation by the SOAP. That's it.
Eatimad?
Actually, in our hospital, most of us are not using the nitrous, and we are not monitoring the patient awareness of patient after that. We are lucky maybe for this, but we had an incident long time ago with the nitrous, and I believe I will not use it.
We will wait. Dr. Hani.
I would use it بصراحة.
طيب, let me talk to you about the history. The history started 2002. There is a school who came, said nitrous oxide is very bad for nausea and vomiting. Everybody believed them. Everybody believed them. Then with time, this group found that the nitrous oxide, not use it, you're going to increase the SIVO. You're going to increase the narcotic. Then when they compare the three things, nitrous oxide, sevoflurane, or the inhalation agent, okay, it caused more nausea and vomiting. So they found that this was a myth. This was not true, but they never published that the nitrous oxide, where they claim that caused nausea and vomiting, is not true. And then people left it because at that 2002, people are looking for day surgery. Now I can say that nitrous oxide is like IV fentanyl, like anything. It will disappear from your body within seconds after discontinuation. Why? You lose this luxury. And you give more narcotic, which will last more with the transfusion, and you use as well Mercivo because of the tachycardia effect of not using nitrous. And then we claim that nitrous oxide causes nausea and vomiting. I think this is going to be in the future revisited again, and nitrous oxide is still the gas of a choice for anesthesia, especially in pregnant women where the MAC requirement goes down to half. So SIVO of 2, we're going to give 1.8. So if you don't have in the background something will cover the patient with pain till the baby come out, where you don't give an analgesic, then you're going to be in trouble. That's a debate. Now, in obstetric anesthesia, we have a religion. And this religion say that half MAC, nitrous oxide, 70%, 30% FiO2 till the baby come out, no nitrous, no narcotic. Now, if you remove the nitrous oxide, so you left with SIVO, which I don't know is going to work, with oxygen, which will work, make the patient remember you and make him alert, then you can take the choice. It's just an opinion, okay? So nitrous oxide, I never seen anybody not use it in obstetric. Agree with what some people talk about nitrous oxide and laboratory surgery, laparoscopy and these things, but please don't bring this debate in obstetric anesthesia. The questions increasing, doctor, and the excitement is getting more. Again, the tranexamic acid use in labor and delivery. And Dr. Eatimad mentioned something good about the machine that they bought, and they forget to bring I think the machine of retransfusion blood, and forget to give the amniotic fluid filter, which alert everybody, please be careful before you buy a car. Make sure that you have a tire for the car. So having this device enlightens us that we can do other things. So tranexamic acid use, Dr. Hanan Eatimad, what do you think?
Yes, I would recommend to use it. You can give
doses.
it.
How much the doses you use? Usually for us, we give 1.5 or 2 gram, or we rate it 150 milligram per kilo. You know, we'll depend on our resident to remember the doses. And Hanan, what do you think?
Yeah, it's the same dose you mentioned, and actually it's in the checklist for placenta Accreta, and we've been using it now more and more.
Great. Doctor, anybody want to pick a question? Please look at it if there is any question.
I think we reached to the end of the session, and want to give the people any time to pray, and I think we would like to thank you all for your attendance and great session from Dr. Hanan, Dr. Eatimad. Thank you, Dr. Tawfeeq. You managed it very well. Make it very excited to everyone.
We hope to see you in this next session. Guess what, guys? We're going to give you 45 minutes to pray. No, till 1:30. Please come. The next session will be really interesting. You're going to see more than what you think. Anesthesia is always challenging. Dr. Hanan, really, we enjoy you in Jeddah with her. Dr. Eatimad from Mecca, Dr. Hani from Riyadh, and Dr. Nasser from Riyadh. Just to say that Jeddah and Mecca and Riyadh is competing. Please be with us in the next session. Thank you very much, everybody.